Welcome to our new chapter of neurosurgical dissection in motion. Today, we are going to review the expanded transorbital approaches. After head is positioned slightly flexed over the Mayfield head holder, an eyelid skin incision, it's performed over the most prominent wrinkle and extended laterally over the lateral epicantthus. Orbicularis muscle fibers are identified and severed. As you can see here, a thin layer of fat often can be found underneath the muscle, which helps in the identification of the septum palpebrae. Then submuscular dissection is carried down to find the orbital rim. Temporalis muscle is disinserted minimally from the orbital rim. Here we prefer to perform a 2x2 lateral orbitotomy to increase the maneuverability corridor and minimize orbital retraction. In this view, we can appreciate the orbital content and the temporalis muscle. The periorbita is dissected subperiostically from the greater and lesser sphenoid wing. A reliable landmark in the lesser wing is the meningolacrimal artery, which should not be confused with the meningorbital band. This is a branch that communicates the ophthalmic artery with the meningeal system and needs to be coagulated and severed in order to avoid intraorbital bleeding. This component of the lesser sphenoid wing is called the sagittal crest. Sagittal crest and the greater sphenoid wing are drilled flat until the meningorbital band connecting the orbita and the temporal lobe is exposed. This step widens the superior orbital fissure. Then the meningorbital band is coagulated and cut to allow the mobilization of the temporal lobe. Here we are separating the dura propria and the meningeal layer using sharp techniques. Then the endoscope is advanced in the inferior margin and superiorly allows to identify the roof of the orbit and more distally the anteroclinic process and optic canal. In this case, we are going to perform an anteroclinectomy using the non-drilling technique. So here we are just backbiting the roof of the optic canal. With the use of Joseph Lambert 4, we are untethering the anchors of the anteroclinic process. By removing the anteroclinic process, we expose the clinoidal segment of the internal carotid artery with the external and internal dural rings. Now, below the anteroclinic process, we are continuing performing the interdural dissection by separating the meningeal layer and dura propria of the meninges, and we expose the third coronary nerve, fourth coronary nerve, and V1. As we proceed down with the peeling of the middle fossa to find V2, we need to increase the surgical corridor by drilling the maxillary strut. At this point, then, we can identify the crystal valley that marks the junction between V2 and V3. Then, with minimal retraction of the temporal lobe, we are able to identify all the coronary nerves in the lateral wall of the cavernous sinus. And further side dissection is going to allow us to find the microscope and see underneath the fibers of the Gasserian ganglion. Using side dissection through the lateral wall of the cavernous sinus over the third coronary nerve, we are able to access the subdural space through the oculomotor triangle. In a similar way, the supratrochlear and infratrochlear triangles are open widely. Using a proper hemostasis, the nerves in the lateral wall of the cavernous sinus can be dissected from the lateral wall itself. And this maneuver allowed to enter the lateral compartment of the cavernous sinus. And as we proceed down, we use sharp dissection techniques to sever and dissect in the microscope. This maneuver is extremely important for sphenoid wing meningiomas in which tumor infiltrating the microscope it can be responsible of some trigeminal pain. Finally, we are communicating the cavity of the microscope with the infratrochlear triangle to open a new corridor into the posterior fossa. Here we are introducing the endoscope into the subdural space through the oculomotor triangle. Now the free edge of the tentorium is cut right below the third coronary nerve. This maneuver allows to mobilize the fourth coronary nerve and increase the corridor into the parapeduncular space. Here we can find the distal branch of ICA, including supraclinoid ICA, anterocoroidal arteries, and PCOM. Through the infratrochlear triangle, we can access the subdural space, find the pons and the superior cerebellar artery. Thanks for watching. Special thanks to our fellows and visiting faculty that make this work possible and perform all the dissections.